Hello everyone and welcome to this audio podcast. This audio podcast is part of the Erythropoiesis edition. This audio podcast is part of a Hurricane Plexar. This audio podcast is part of the Labonix Vendip. This audio podcast as part of a Storm Robotics production. This audio podcast will bring together some conclusion or sort of a conclusion or conclusions in around this works as part of this audio podcast series. So the objective was to identify and establish whether renal allografts in pediatric recipients are able to have a prognosis for 10 years or 20 years post transplantation with the aid of immunosuppression therapy, and whereby it can be whereby there's a sort of an introduction to anti-rejection therapy or immunosuppression therapy with reduced nephrotoxicity. So pediatric renal sufferers unfortunately have a lot to deal with if diagnosed with chronic renal failure. The medication will always be long term, which can lead to various side effects, though can be avoided if another drug is used to counteract a specific side effect. And at the same time, must be acknowledged that the drug would have another effect. Thus, newer protocols are designed with the aim of lowering regimen or doses, which hopefully in turn reduce the incidence of nephrotoxicity and renal impairment while maintaining potency. Thus, Serology or SRL has brought new hopes. Serology had brought new hopes, but understanding whether it could be used more than a prophylactic required to be identified. Investigations also implied that sirolimus is a non-nephrotoxic agent capable of competing with CSA for the prophylaxis of AR or acute rejection in renal transplantation or in transplantation generally. However, it should not be combined with CSA cyclosporin, for example, for more than 2 or 3 months. Sirolimus or SRL sort of against CSA and FK506 and CSA and FK506 and some and for example azathioprine, for example, is a more promising have been evidenced as a more promising immunosuppressive regimen towards the rationale for its use in transplantation. Which drug is used depends again on the child's or pediatrics sort of renal condition, and the decision of the pediatric specialist. Neither drug has appeared more victorious over the other at this point. A more structured research is required again to understand nephrotoxic concern in pediatric recipients, and this should include newer medications, therapeutics being available in this specialty, as part of the specialty of clinical medicine. Sirolimus has also proved a potent immunosuppressive drug generally in humans. In humans, and it has been successfully used with and without CSA, and might be a good alternative to calcineurin inhibitors Its original mechanism of action and toxicity profile make it a true immunosuppressive immunosuppressant. Given the characteristics, other combinations need investigating in randomized studies. Preliminary data showed that FK506 could be an efficient and safe partner with SRL. There is no definite therapy recipients are prescribed, as well as having to provide best appropriate transplant for prolonged survival. More research needs conducting to provide most according immunosuppression therapy regimen. Thus, both MHC, Major Histocompatibility Complex, and Human Leukocyte Antigen characteristic matches with low dose anti-rejection therapy. Therapy can improve renal transplant prognoses, allowing allografts to survive from allograft prognoses from between 10 to 15 years with good management, and fewer effects post-transplant on pediatric recipient, and reduced probability of nephrotoxicity and associated abnormalities. The problem here is at the same time there is a shortage of donors that thus lack there is a shortage of donors and thus lack of education based in around the nephrology specialty as well. CSA, FK506, and sparring regimens which use reduced doses of CSA can be the best sort of best current option for reducing nephrotoxicity in pediatric recipients. The chemical immunosuppressant MMF has been part of these type regimens that provide improved renal function whilst maintaining adequate suppression. Such regimens should reduce patient morbidity and mortality. Monitoring whole blood concentrations of immunosuppression is an essential aspect of treatment in pediatric renal recipients. Therapeutic ratio has been evidenced as being very low. Also, the valuable pharmacokinetics of anti-rejection therapy, in particular CSA, among recipients and patients makes accurate estimation of the initial dosage difficult. The variability results from differences in the therapy absorption, distribution, and clearance. Another important aspect in the distribution of CSA is that it's highly bound to erythrocytes and plasma lipoproteins. A low concentration, and when the packed cell volume is low, the concentration of plasma bound fraction becomes more important to the disposition of the medication. Both CSA and its metabolite are excreted in bile, and a little appear in the urine. Thus, renal failure does not alter the elimination of CSA. At the same time, it must be acknowledged that with all immunosuppressant regimens, there is a little quantity of the drug in urine. It's this that can also contribute to the nephrotoxicity. At the start of treatment of immunosuppression post-transplantation, when therapeutic dosage in pediatrics is not clearly identified, measurement of CSA FK506 or tacrolimus is necessary in adjusting the dosage in order to achieve a target concentration. This can cause complications toward toxicity. It has It has to be done. It has to be done, unfortunately, until target concentration in pediatrics children can be established. Otherwise, this can take a while. Measurement of target efficacy is has been evidenced as every 2 days until satisfactory results have been retrieved. If toxicity is suspected at any time, or if compliance is in doubt, specialists and professionals resort to blood immunosuppression levels, anti rejection measurements. This measurement proves useful when potentially interacting drugs are introduced or withdrawn from recipients. At the moment, or at least in evidence, the best way to determine nephrotoxicity in immunosuppression regimens is by appropriate plasma concentration identifications. New regimens are being have been researched again. Sirolimus or rapamycin, provided providing there is a there is there is that there is there are investigators and researchers that can compare against other immunosuppression. And in children on pediatrics, it's hard to establish peak medication levels or therapeutic levels, which can lead to overall complication in the child's renal care. Then there's the complication with children or pediatrics on other medication to control other illnesses such as ABP. The level of renal function below which the dose of a drug must be reduced depends on whether the drug is eliminated entirely by renal excretion, or is partly metabolized, and how toxic it is. For many drugs with only minor or no dose-related side effects, very precise modification of the dose regimen is unnecessary, and a simple scheme for reduction is sufficient. For more toxic medications with a small safety margin, dose regimens based on GFR are normally utilized, or should be utilized. For those where both efficacy and toxicity are closely related to plasma concentrations, recommended regimens should only be used as a guide to initial treatment. Subsequent treatment must be adjusted according to clinical response and plasma concentration. And though for immunosuppression, apart from plasma concentration, creatinine and urine samples are useful to detect drug toxicity. The total daily maintenance dose of drug or therapeutics can be reduced either by reducing the size of individual doses or by increasing the interval between doses. The same applies to anti-rejection therapy or immunosuppression, but toxicity can tend to accumulate slowly in initial stages post-transplant. And so for some drugs, including immunosuppression, if the size of the maintenance dose is reduced, it would be important to administer a loading dose if an immediate effect is required. This is because when a patient or recipient is given a regular dose of any drug, it takes more than five times the half-life to achieve a steady plasma concentrations. As the plasma half-life of drugs excreted by the kidneys is prolonged in renal failure, it may take many days for the reduced dosage to achieve a therapeutic plasma concentration. The loading dose should usually be the same size as the initial should usually be the same size as the initial dose for a recipient with normal renal function. This partly answers the question stated in this works earlier: if a reduced nephrotoxic anti-rejection therapy is available, can it work alone? There are two answers. Firstly, if a reduced nephrotoxic immunosuppression was introduced to allow longer to allow longer longevity or prognosis in around pediatric renal allografts post transplantation, then yes, it could work, providing there is a decent donor or cross match for the pediatric transplanted recipient. Unfortunately, at the moment in renal medicine or in nephrology, this would also mean that an increase in other regimens for any other symptoms. Secondly, it might not work sufficiently because it could take a while for the reduced dosage to achieve a therapeutic plasma to achieve therapeutic plasma concentration. Thus would result in a secondary immunosuppression regimen. Thus, though if MHC and HLA match is good, this would not be such a disadvantage for the pediatric recipient. Apart from examination of clinical procedures to measure nephrotoxicity in pediatrics, what about other? So another question is, what about other modalities to distinguish, for example, to distinguish nephrotoxicity? What can and also what can give better diagnosis in around toxicity? So differential diagnosis is principally from rejection. Differential diagnosis principally from rejection, critically essential because of the treatment required differs dramatically. Blood levels of the drug are useful when they prove to be above or below target concentrations or therapeutic range. Toxicity or rejection is possible within this range, and unfortunately, in both disciplines, in both specialties, pediatrics and adult nephrology, there is no definite dose or regimen that is established again, so that less toxicity will occur or none at all. Thus, rejection of allografts and toxicities can occur simultaneously. Another question as part of these conclusions, are there more tests? Are there more tests that could prove to be more helpful in making diagnosis for nephrotoxicity? So carrying a biopsy can make histological examination and pathological investigation of renal structure. This procedure seems to be informative and aids in early diagnosis of nephrotoxicity. The disadvantage of this method, like many other complex routines, is that a structural change in CSA or FK506 toxicity often lack sufficient specificity to yield a conclusive diagnosis in isolation. Normal or near normal histology is a valuable pointer to functional toxicity during the first few months post transplantation, provided that problems of blood supply and neurological complications such as urinary obstruction have been ruled out. By contrast, diffuse mononuclear cell infiltration with tubulitis usually means acute cellular rejection with hypersensitivity, a much less frequent alternative. Isolated focal cellular infiltrates may usually be ignored. CSA is a likely culprit when primary non-function persists for weeks in the presence of pure acute tubular necrosis. Reduction of the dose or switching to prophylactic suppression therapy suppression therapy. At the same time, it's true to say that whatever diagnosis is used to establish immunosuppression toxicity, the diagnosis can rarely be evident on its own. Thus, more than one type of study or investigation is recommended to obtain better and more established data. So, CSA or neural and tacrolimus at FK506 remain the primary have remained sort of primary immunosuppressive drugs of choice in pediatric recipients, but the nephrotoxicity has led to an increase in use of triple therapy on low dose CSA, FK506, MMF, and or azathioprine with corticosteroids. And so new drugs or therapeutics are available, though the more drug regimen a patient or recipient has, the more probability of renal dysfunction or insufficiency, thus unsuccessful prolonged allograft survival or prognosis. At the moment, at the moment, the challenge still proves quite challenge. Still proves still proves difficult. But pediatric nephrology, pediatric nephrology or pediatric renal medicine has most at the same time has progressed has progressed in sort of the in some of the aspects around aspects of clinical and clinical practices and laboratory medicine. And so Yeah, and so it is it is it is likely that mycophenolate mofetil MMF and or tacrolimus FK506 will become increasingly used in the next in the next few years, or and if sirolimus SRL becomes more acknowledged, and this too will be used or utilized. This is because the number of early rejections under regimens using these drugs appears to be lower, and lower rates of early rejection or AR acute rejection in turn are correlated with a better longer term function and allograft survival. Allograft survival and incidence of rejection appear to be similar with regimens in current use, except that allograft survival prognosis is lower and rejection more common with regimens containing only prednisolone, for example, and or azathioprine, compared with those containing CSA or cyclosporin, and sort of newer sort of pharmacotherapies. However, morbidity, for example, infection and skin cancers may well differ, and early rejection rates are lower with a newer newer pharmacotherapies. It is likely that a greater diversity of regimens will be used in sort of prospectively to tailor therapy more accurately to individual recipient requirements. Newer agents such as those those mentioned have been part of clinical investigations or clinical trials, and only further controls and studies will allow recommendation will allow important comparisons to be made. Until these are completed, outcomes need careful auditing to allow accumulation of informative data. The choice of immunosuppression regimen has implications, has varying implications, which will also need sort of interrogating, but at the same time data are needed, data are needed to compare against a varying spectrum of pharmacotherapies. And so with that, unfortunately, even with reduced nephrotoxic medication for pediatrics or those for pediatric recipients, this may not work accordingly unless issued with more potent immunosuppressant regimens. Simply because to obtain therapeutic range, toxicity will have to occur within the pathway of absorption in order to maintain drug efficacy and suppression of one's immune system. It's not a matter of just one examination to determine a renal toxicity. A whole group of investigations on individual pediatric renal recipients should be should be encouraged or propagated. The disadvantage here at the same time is that this can take a lot of this can have other disadvantages and implications. Thus, it's hard to establish this kind of regimen, in the field, in the specialty, within the specialty, and many many specialist sites do not have the resources, and the fact and at the same time the fact is that it would be a challenge to do this on it would be it has been a challenge to do this to determine sort of aspects of toxicity, toxicity or nephrotoxicity across the population, across the population, and so until there is improvement in investigational techniques, more education, and reduced or reduced therapeutics in pediatric renal recipients, in pediatric recipients is it has still been pivotal, but at the same time, unfortunately, nephrotoxicity still has a dominant basis. That draws this audio podcast to a close, and this has been an audio podcast as part of the Erythropoiesis edition. This has been an audio podcast as part of a hurricane Plexar. This audio podcast has been a part of a Labonix Vendip, and this audio podcast has been part of another Storm Robotics production. Thank you.